Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. And we wanted to talk a bit about something that a number of viewers have discussed with us. Remember, we have a lot of people who, like I always say, want quality of life. We have a lot of people who are either retired or they are active, involved with weekend activities like tennis and golf and things of that nature. And there's a lot of questions relative to foot and ankle care. And you say, well, why only foot and ankle? Well, because there's a lot of people that have problems with their feet and they ask questions. So I said to myself, well, who am I going to ask to come to visit with you today? Well, a longtime friend of Nova Southeastern University, a longtime friend of the community, who is involved with programs at Westside Regional Medical Center right here in Plantation. And we have Dr. Steven Spinner, who is a doctor of podiatric medicine. Welcome, Steve.
Thank you very much. Thanks for having me.
I'm glad to have you here. And we have a resident in the field of podiatric medicine, Calvin Rushing, who is a doctor of podiatric medicine, but is under, I guess, the tutelage and training and oversight of Dr. Spinner at Westside Regional. Welcome. Welcome to have you. Glad to have you here.
Thank you.
And as I found out, we have a relationship. Your wife is in the dental school here at Nova Southeastern University, so congratulations.
Good, thank you.
Dr. Spinner, there are so many people that really, it's everything from ingrown toenails to, bunions to cracked ankles to feet burning to, there are all these questions that come. So it's going to be a pretty wide open show relative to podiatric care. So why don't you just tell us generally what a podiatrist is able to do, can do relative to their work and profession?
Sure. Let's start with the training.
Yes, sure.
The training basically has evolved over the years, as I'm sure you know. Most applicants to podiatric medical schools currently have a 4-year undergraduate degree from a university. They then go through a 4-year podiatric medical program. At this point in the evolution of the profession, there's a mandatory minimum of 3 years of residency or postgraduate training after their 4 years of podiatric medical school. There are essentially 2 tiers of residencies. There is a general residency, which is in podiatric medicine and surgery, and then there is a podiatric medicine and surgery residency with an added credential in reconstructive rear foot and ankle surgery. So the program at Westside is a podiatric medicine and surgical residency program with the added credential in reconstructive rear foot and ankle surgery. The program has been at Westside for over a decade. It's one of the nationally recognized programs in the field. Following that 3-year course, there's an opportunity for those graduates to go into fellowship programs, which can last anywhere from another 1 to 2 years. So with regard to the profession has evolved tremendously over the last 20, 30 years, whereas previously one particular podiatrist would kind of do everything from routine foot care to ingrown nails to diabetics to surgery. It's gotten so broad that basically it's divided now into compartments. So there are subspecialties within the field. There are podiatrists who do mostly diabetic evaluation and foot care. There are sports medicine doctors. There are doctors who specialize in non-operative orthopedics of the foot and ankle. And then there are basically 2 tiers of surgical specialty within the profession. One is general foot surgery, and then there's the people who graduate from the programs with the added credential in reconstructive rear foot and ankle. So when you ask what they take care of, if it's in the state of Florida, if it's below your knee, a podiatrist who's trained specifically in that venue can take care of anything that you have, from ingrown nails to diabetic neuropathy, to complex open ankle fractures, to ankle joint replacements, lower leg fractures. Podiatrics, which is the care and treatment of kids, to Podiatrics, which is the care of the elderly population.
I appreciate your complete answer. Dr. Rushing, how does that feel being called Dr. Rushing? Pretty good, right?
It's pretty good.
Right.
It's pretty good after 4 years of
Go ahead.
school loans.
Go ahead. Say what you were going to say. You were going to say after.
It's pretty good after 4 years of student loans.
Oh, wow. That's, you don't worry, you'll take care of that because you're going to have so many patients and you're going to be working with a lot of different people, and that all takes care of itself. I know you were taught at Barry College of Podiatric Medicine. It's always one of our sister schools. We have a lot of things we do in common. They've been very helpful with us, and we've been trying to be very helpful with them in our relationship with our nursing programs. So talk to us about your education and what you're doing with Dr. Spinner.
So as far as our education, kind of like Dr. Spinner said, the gamut of pathologies that podiatrists are dealing with today are diametrically different to what our forefathers were dealing with 30 or 40 years ago. There's been an increase in the demand for surgery, mainly because evidence is showing that some of these conservative modalities just aren't working. So some of our residencies have been starting to be geared more towards limb salvage, especially in diabetics, as well as reconstructive surgery for people with post-traumatic arthritis that are 40 or 50 years of age. So our education has definitely broadened from 30 or 40 years ago, and part of the reason I chose to go to Dr. Spinner's program is because his reputation is known throughout the entire state. He was probably the only director that, when I was traveling as a student, third and fourth year, I was hearing about him in Colorado, I was hearing about him in Boston, I was hearing about him up in North Florida. And this seemed like the perfect match to get that kind of training, and also for my wife and I, since she wants to stay here and do the dental program. So it was kind of a perfect match, and I submitted as a ranking, and I was incredibly fortunate and blessed to end up at Westside.
Well, that's great. It's always good to hear, and you'll understand because I'm a little older than you are, but it's always good to hear a young, new professional that's going to be providing care to the people who view this show, to know that that there is a willingness on your part to receive the best education you can have, the best clinical and residency and operative procedure view and training as possible, because that will make you a better, not only podiatrist, but in my mind, a better person. So we're glad you're here. Dr. Spinner, one of the issues that comes up often, and it was mentioned to us by our viewers, is neuropathy. Explain what neuropathy is and explain why there's so much that comes your way as a podiatric professional relative to neuropathy, foot pain.
Sure. Neuropathy specifically, as you know, is an affectation of nerves where the nerves fail to conduct impulses normally. The presenting complaint can run anywhere from just some basic numbness and tingling all the way to severe disability with pain syndromes and motor dysfunction where the limb stops working and patients have gait disturbance. So the patient population that generally presents with this are patients with the overwhelming number of patients are patients that are affected with diabetes. And as you know, the diabetes in this country is epidemic. The numbers are astounding when it comes to how many new cases of diabetes are being diagnosed every year. So the real issue with neuropathy is that the foot becomes what we call insensate, which means that patients, aside from having these peculiar feelings going on, lose the sensation to perceive pain. So when that happens, they can step on a splinter, they can get an infection, they can injure themselves, and because the protective mechanism of pain is not working, these pathologies can progress to life and limb-threatening issues. So the combination of diabetes with their blood sugars being out of control, the neuropathy and the vascular disease that comes along with it makes for a perfect storm of issues which can lead to some devastating life-changing, life-altering events. So the whole science of neuropathy and the treatment of neuropathy has advanced tremendously. There are all kinds of medications out there that we now use. There are experimental therapies which involve injection therapy and some electric stim therapies. But this is becoming more and more a common presenting complaint, especially in the podiatrist's office.
Yeah, because we have like I said, we've had a number of requests to talk about what people will, they may not call it neuropathy, but they call, I get this terrible foot pain, you know.
Sure.
It's from the ankle down and whatever, and I get cramping and things of that nature. And I'm sure that some of it is not necessarily only neuropathy, for example, muscular cramping, or you tell me.
Well, of course. I mean, the generic complaint of pain in the lower extremity, some of them obviously are neuropathic in origin. The majority of those patients obviously come in with some musculoskeletal dysfunction, or they're post-traumatic, or they're recently traumatic, or they have chronic long-term disability from deformities that have been acquired either as kids or in adulthood. So obviously the majority of patients come in and say, hey, my foot hurts or my ankle hurts. So at that point, the diagnostic paradigm is established, and you try to rule out and rule in what the patient's complaint is. Most of my function in the practice is in the reconstructive surgical aspect of it. I've got partners who specialize in wound care. Dr. Madeline Ramil specializes in wound care in the office. She does a lot of the limb salvage for us. She does most of the hospital work with regard to diabetics and patients who come in with infections and ulcerations from diabetes. My partner, Fred Chussed, does everything in the office. He does everything from wound care to reconstructive foot and ankle surgery. So it's kind of become compartmentalized over the years, because I don't think that one of us really can stay up to date with everything that's going on in the profession.
But one of the things, and I guess Dr. Rushing, can I call you Calvin?
Sure. Yeah,
Okay.
of course.
I just feel more comfortable calling you Calvin, if you don't mind. But as you are being trained, and I know that and you have the honor of working with Dr. Spinner and his colleagues, you begin to see how healthcare is moving together as a interprofessional, interdisciplinary service, professional service to these people out here, the patients. I would assume in your training, in listening to what Dr. Spinner was just saying, that if you're in, for example, the OR or even the office, you're going to see something, and you might be called in because that might be something of your specialty area. Do you find that?
I do. So as far as diabetes, we can all agree that it's an epidemic. There's 29 million Americans who are affected. It's about 10% of our population. Worldwide, we're looking at over 400 million people, with projections as high as 600 million, in the next few decades. The interdisciplinary approach to diabetes has by far improved the limb salvage rates. If you look back at some of the research in 1983, that what we used to always classically quote by Burgess was that all diabetics who underwent an extremity amputation would need a contralateral, meaning on the other foot, within 2 years. That's false now. The interdisciplinary approach with the vascular surgeons, with the infectious disease specialists, with the hospitalists, with the endocrinologists, with podiatrists within our field who might specialize in different aspects of the diabetic care is improving these people's outcomes, and we are preventing major extremity amputations. If you look at major extremity amputations, meaning a below-the-knee amputation or above-the-knee amputation, the 5-year survival rate of diabetics undergoing an above-the-knee or below-the-knee amputation is 60%. If you look at the top 10 most common causes of cancer, the survival rate is only worse for one, and that's lung cancer. So preventing amputations, being major amputations in diabetics, has to be at the hallmark of what we're trying to do as far as limb salvage in that patient population. And I think we're doing a good job doing it so far.
Well, it certainly is. In fact, we're here at Nova Southeast. We're very involved with the American Diabetes Association. In fact, we have ongoing discussions of creating a center of, I don't want to call it a center of excellence, but it's a center of knowledge for the diabetic population in the southeastern region of the United States. So we're talking about that right now. But it's interesting because when you think of diabetes, you have to think of the precursor often to diabetes, which is obesity. And obesity is not epidemic, it's endemic. We have, for the first time in the history of, I guess, some of the statistical analyses available through our healthcare professions, this year was the first year where the lifespan has not gone above where it is. In fact, in some cases, in some origins, based upon where you're from and some genetic leanings, it's actually lower. And a lot of it is laid at the feet of improper nutrition and obesity. So I guess you both get to see some of the consequences early on, because obesity seems to be prevalent to a very, very large extent in people under the age of 40. Dr. Spinner?
Obviously, a lot of the patients who present to our office with complaints in the lower extremity, those complaints are precipitated by having an increased body mass. It's just common sense that the more weight you're putting on this tiny object at the bottom of your leg, it's going to be directly proportional to the amount of pathology that the patient's going to have. And we're not nutritional experts, we're not, weight counselors, but clearly that conversation has to be part of the examination and the counseling to the patient when they come in with foot or ankle problems. You have a very large patient come in and they want to know why their feet hurt. So you have to delicately explain the mechanics of this coming down to this, and the stress per square inch is just overwhelming. So there's no question that we're seeing more and more of that. And we see a skewed portion of the population, obviously, because their increased body mass is related to increased pathology in the foot and ankle.
But again, both of you brought attention to diabetes. But well, like I said, one of the dominant precursors to diabetes is obesity.
Of course.
So you have to start out at the right spot, and that's why the interprofessional, interdisciplinary relationships that you both enjoy at Westside Regional is something which I think is really the paradigm of the future. What do you say, Dr. Rush?
I would agree. I mean, on all of our diabetic patients, on top of the vascular, the infectious disease, the endocrinologist, we're almost always uniformly consulting nutrition for that reason, to counsel them regarding the importance of blood sugar. Once diabetics' blood sugar reaches, varying levels depending on what you're citing, but about 170 milligrams per deciliter, it prevents their cells from effectively being able to fight off simple infections. So a wound that gets a minor outbreak of cellulitis turns into something that could be limb-threatening, which over the course of 5 to 10 years can be life-threatening. And again, with diabetics, the frustrating thing for a lot of medical professionals is that they don't understand that for diabetes, there's an emotional distance from the severity of their condition because they have neuropathy. And so it's always tough to try and counsel diabetics regarding the severity of the condition because they do have that emotional detachment.
Dr. Spinner, again, I'm glad we spoke about this, but like I said, the viewers presented a lot of information they wanted to know about. My God, look at my feet. They've changed, and they're, I got these ugly toes, and I got ingrown toenails, and I got bunions. I know that's very primal when you talk about some of the work that you do, but it is of great interest to our viewers. So maybe we can talk a bit about that.
Sure. There are lots of age-related things that happen to us, not just with our feet. So our feet are just an expression of the aging process. And being a mechanical structure, mechanical things break down over time, not just with your feet, but with any system. So the feet suffer tremendously from years and years of either abuse or improper shoe gear or just the aging process. digital deformities occur, skin and nail changes can occur. You have pain syndromes which can occur because the feet now mechanically are not functioning as well as they used to when we were younger. So these are, especially in South Florida, these are prime focuses of what we see in the office and what our treatments are designed to not head off at the pass, but at least to be able to treat when they become problems. And as you know, the aging population has deformities which sometimes can be corrected if the patient is a surgical candidate. Sometimes they have to be supported by either shoe gear or shoe modification or lifestyle change.
You know, again, we are an interesting state. We have the highest percentage of people over the age of 70. We have the highest numbers of people over the age of 85. We have a lot of people, and yet we have the largest growing population from 0 to 15 in the nation. So our schools are not prepared for all of these young people. But with the people that I'm talking about, you know, the active individuals over the age of 65 who want to, you know, have a quality of life. I mean, you know, whatever. I want a quality of life. I want to play golf. I want to walk. I want to dance. I want to whatever it is. And they have these foot problems. Obviously, both of you will care for those problems, or people associated with your practice will. But how often do you think an individual, we all say, every time I get a physician on the show or a healthcare giver on the show, we ask, well, how often should someone come in for a checkup? So I want to ask you, how often should someone come in to see Dr. Spinner or his colleagues for a foot checkup?
I think probably twice a week would be good.
Well,
you know, it's a great question, and it really depends on the patient. If there are comorbidities such as diabetes or vascular disease, without the presence of an acute problem, we typically recommend an exam every 2 months. And most of the insurance companies understand the importance of preventative foot care in that at-risk population. So the simple answer is if you're at risk every 2 months. If you're not at risk, a screening exam I think would be recommended for everybody just to get baseline studies of their circulation, their nerve status. But the real important thing in the aging population is to not let a small problem become a large problem. Obviously, when things first present, we all, as human beings, have a tendency to try to put them off or ignore them or think that they'll get better, because for the first 40 years of our life, that generally was true. Things did get better without having to go to a doctor. Past the age of 40 or 50, that's not necessarily the case anymore. So really, it's a level of awareness of your own body that when you see things going wrong, not to ignore them, but at least seek professional help, whether you come into a podiatrist's office or your family doctor's office, to try to head those things off at the pass. Because obviously, it's much easier to take care of things when they're not acute than to let them progress and become more problematic.
well, Dr. Calvin Rushing, now that you heard Dr. Spinner give you advice to have people come in twice a week, only kidding, only kidding. But really, most people who are looking for quality of life, do you agree that they should, obviously there should be some kind of an initial exam to be able to understand the individual that's in front of you, but should say Dr. Spinner says every couple of months, but at minimum, don't you think that maybe it should be correlating with individuals that have full body check, you know, their home, the blood screening or whatever, twice a year? What's your thought?
So my family, my mother's side is largely affected by diabetes. So what I always tell them is kind of the same thing I always recommend to patients is at least every 6 months at the minimum. Again, it's always patient specific. So if someone has, an open wound, an area of concern, they have bony prominences that predispose them to infections and complications, they've been in the hospital before, they've been on IV antibiotics. Of course, with those patient-specific factors, more often than 6 months. But what I always tell my family and my patients by extension is that at a minimum, every 6 months if you're a diabetic is what I would recommend, minimum. Every 2 months in a perfect world, but people have busy schedules. Sometimes that doesn't work. So at a very minimum, 6 months.
Well, good. Well, we're down to the last minute of this show. It goes by pretty quickly. But I think we hit on the issues that the people asked us to talk about. I just wanted to bring to the viewers' attention that the broad presentation of services that podiatrists provide for the viewers and others, and certainly with the vastness of or the extraordinary program that is involved at Westside Regional Medical Center with their residency program and with the ability to do everything that you and your colleagues do. I want to thank both of you for being here. Dr. Calvin Rushing, resident at Westside Regional Medical, and hopefully sitting not necessarily at the feet of, that's a podiatric comment, but really at the mind and of Dr. Spinner and his colleagues. I hope that you turn out to be another Dr. Spinner. How about that? Is that pretty good?
That's definitely something that I can aspire to be.
Good. And Dr. Spinner, what can I tell you? We're so thankful for your long-time association with Nova Southeastern University. It will go on and on and on. In fact, I was just talking to Dean Wallace just the other day, trying to figure out how we can get you over here more often. So
It'd be my pleasure.
We thank you for your service. We thank you for your knowledge. And really, more importantly, we thank you for your caring, because you do carry on your primary patient, Dr. Morton Terry, in that the art of medicine still is alive inside of you. So I'm glad that you're here. Folks, I hope we presented some answers to some of your questions. I hope this offered some view of podiatric medicine. And remember, like I said, healthcare is moving in an interdisciplinary, interprofessional world. And I would hope that you take advantage of the knowledge and services of the podiatric professionals that are sitting in front of us right now. I want to thank you once again for showing up. We're glad that we were invited back into your home again this week. And remember, this program is yours, so if you have any questions or you have any answers you want, there's a telephone number and an email address right here. And remember, as I always tell you, take good care of yourself. And I heard varying comments here, but at least twice a year and maybe every 2 months, but you have to make up your mind. You have to take good care of yourself, and by doing that, you need to show up at your physician's office. And remember, give them all information. Don't hold back on information. This program is called Dateline Health. We come to you from Nova Southeastern University. My name is Fred Lippman. Until next time, see you.